I'm going to speak, basically based on my experience on practicing in Kenya for nearly 2 decades, being involved in cervical cancer research there and working with University of Washington and Aga Khan University for a number of years implementing cervical cancer screening programs. As been touched upon, a lot of this is really looking at cervical cancer burden and why are we screening so much and how it affects LMICs. It's the fourth most common cancer among women worldwide, and it particularly affects us in LMICs where we have the highest incidence of cervical cancer disease. And you can see, in this slide, really you have the darkest blue of highest incidence, really affecting areas like Latin America, particularly sub-Saharan Africa, where now we have really, it's the second most common cancer among women in LMICs. And 90% of deaths due to cervical cancer are in LMIC regions. Why is this? Well, we have a lot of pap smears, cytology screening that happens in high-income countries or in the West, where women get screened every 1 to 3 years. But in LMICs, we have much reduced screening. We don't have that luxury, and women are lucky to even get one screening in a lifetime. You see here that in this study by Gakiru et al., looking at developed countries, at high-income countries, the effective coverage of cervical cancer screening is more around 63% or so here, whereas compared to this in LMICs, you see it much lower, around 19%, really affecting then women who are older, who are at more risk of cervical cancer, really even having less screening. So this disparity is really striking when you look at it here. It means that in places like Malawi, Ethiopia, Bangladesh, women are reporting not over 90% of women there are reporting not having ever had a pelvic exam. So what barriers are there to screening, and why is what's happening here? Well, obviously, for an LMIC, the main issue is economics, is about money. LMICs account for 84% of the world's population and 9% of the disease burden, but it has only 20% of the GDP and 12% of health spending globally. So what that means is that you just have a lack of labs, lack of clinics, equipment, and supplies, and a lack of facilities to actually train the staff and get them up to speed to be able to deliver these services. It also means that the patients themselves can't afford the transportation costs to actually get to these screening services, even if they're offered for free. So economics plays a really big burden. It means there's a limited resources when you're now competing with other medical problems. Non-communicable disease like cervical cancer has to compete with infectious diseases, which are of greater concern to a lot of LMICs. They are now dealing with TB, malaria, HIV, which tend to get to the top of the list, as well as maternal infant mortality. So you have cancer, unfortunately, not placing a big concern. Social issues are there as well. You're dealing with illiteracy in places like Kenya. We have a literacy that's almost 40%. So you have an education that needs to happen about cervical cancer and its importance to be screened. You see one of our workers here educating women about the importance of cervical cancer screening. But what we face there is that some women think, well, why do I want to get screened? Getting cervical cancer is a death sentence. Why do I want to know that I'm going to die? They aren't aware that there's actually treatment to actually prevent the cancer from them getting it. So there's these beliefs, there's the communication that has to happen. These are important issues and barriers that we have to surmount. And finally, there's political barriers that are there. There needs to be the will to actually do something about screening. Most of the programs that are happening are pilot programs. They're run by NGOs. They're not necessarily national programs. A lot of the national programs depend on these pilot programs and NGOs to deliver services. It doesn't mean that they are not delivered themselves from the government setting. So what does this mean in terms of now the principles of screening? Therefore, we need to have space that's accessible to the general population. It needs to be not at a tertiary care center, not in a hospital that's very far away from them, but at a primary care facility or at a mobile clinic that's close to them so they can afford to get to that place. It can't rely on highly trained doctors or lab personnel to actually perform these tests. These tests now have to be done that require less education, less training, because there's just not that much availability of those staff to do that. And the more that these results can be done immediately and be available quickly earlier as soon as possible, the less likely we are to lose patients to follow up. If they can be done immediately, it means that they can stay there, they can get treatment. If they are now having to come back for the results later, that's just another gap in terms of them being able to know what the results are and then get treatment. So the sooner that we can get those results, the more important it is. And finally, and probably most importantly, we cannot separate screening from treatment. I can't tell you how many times I've seen these screening programs really tout their success by saying we screen thousands of women or tens of thousands of women, but when you ask for data about how many women they've actually treated for precancerous lesions, they don't have that data. They don't know those numbers. And when you look into it, you find that most of these women actually didn't get treated. They were referred to a tertiary care center. They didn't go there. They didn't actually get precancerous lesion treatment. And so it then becomes really ineffective. The screening is really worthless without accompanying treatment that has to be there. So what cervical cancer screening methods are there for us at LMICs? Well, obviously cytology is the gold standard of what is used in high income countries, but it is the most expensive test and it requires the most laboratory infrastructure and referral network, as well as colposcopy and biopsy in order to follow up. It's something that's out of the reach really for most women in LMICs, and it's not something that we can depend on, unfortunately. What has been done is using VIA or visual inspection with acetic acid or with Lugol's iodine. This is now something that can be done with store-bought vinegar. And literally in Kenya, we actually go to the store, we buy the vinegar. This can be applied to the cervix, and you can look at and see immediately the aceto-white lesion and use cryotherapy. And you see one of our treat program assistants with a cryotherapy gun in the corner, now treating women immediately with that. So VIA is actually a cornerstone for a lot of what LMICs are doing these days to do cervical cancer screening because it's so inexpensive. It can be done, at the site. But the problem that it requires still training of the nurses and the upkeep of their skills, and the varying sensitivity and specificity of VIA really is a problem because it really depends on the skills of the nurse. It is highly subjective. So where does HPV testing come in all of this? It really is the future, perhaps, of what we're able to offer for women, and it's very promising. We've been going through this a little bit earlier by some people talking about CARE HPV and Expert HPV, the CEPHE test. Both of these things are available to us at LMICs and are relatively inexpensive. CARE HPV has been around a little bit longer. It's about $15 to do, and it's something that we've been using in research projects. Unfortunately, in places like Kenya, it's not been commercially available, so that even though it's inexpensive, it competes with hybrid capture 2, and therefore we've seen actually that being offered more widely than CARE HPV. Expert HPV is something that now is offering tests turnaround time about an hour, as you heard before, which is great. It can be offered individually. So this is something that is becoming really more of a point of care test that is going to be helpful for people and helpful for us. The CARE HPV requires now filling a 90-some well that can now take a week or two to actually get enough women to actually have the test. So HPV testing offers us opportunities. There's decreased risk of subjective interpretation. It's easier to administer. Now with something like Expert HPV, there's point of care tests with immediate results, and it can be coupled with VIA to actually triage women. But there still remains challenges. It still is too expensive. We still are not using this widely yet. How can we actually address this? It still requires equipment, electricity, and a supply chain to actually get that. I've seen many equipment lying in clinic unused just because you don't have the supplies or reagents to actually run it. Something with CARE HPV still requires batch testing, which means that women cannot get those results immediately. Even if there is a turnaround time of 3 hours, you actually have to get enough women to actually fill all those wells. And then finally, and most importantly, as I said before, it still requires access to treatment. If the treatment is the rate limiting step, it doesn't matter how good or how quick your HPV testing is, it's still not going to actually amount to much. So what about HPV vaccine? This is something that's been available from 2006. It protects against 2, 4, 9 types of HPV. WHO is recommending it for pre-adolescent girls between the ages of 9 and 14. Why are we still doing screening? Why are we not focusing on immunization? It should be something that is really cutting this short for us. Well, what's interesting in studies that have been recently published in Lancet by colleagues and Brisson et al., you're looking at the need for screening is still there. If you look at the status quo here, in the darkest red, you're seeing really, as I said before, sub-Saharan Africa really being hit most with cervical cancer incidence. And if you see in the middle here with the vaccination, you see that we start to get to the elimination numbers of less than 4 per 100,000. That's represented in the darkest blue here in sub-Saharan Africa and other parts of the world, but it doesn't reach complete elimination. You're getting this down to about 60%, but it really requires now the screening that you see here in the bottom and 2 lifetime screening for us to really get to elimination targets. So, vaccination alone is going to be very helpful, but we actually really need to still continue to have screening if we're going to make a difference to get to elimination. And this really becomes more pronounced even when we look at mortality. You look at the status quo here on this line at the top here, you have 13 deaths per 100,000 women if you do nothing. But you see a drop here when you start to have immunization, but you see how far out in the years along the x-axis here it takes for us to see a drop in mortality. And whereas if you start to see now here, if you start to do the screening right away, by 2030, you're seeing a 30% drop in mortality. And by 2070, you still see a 30% drop. You just see much earlier effects of this, whereas you're not going to see effects from vaccination, as you might surmise, until later on, and these girls grow up to be women. So this huge difference is really going to make effects for us on mortality. It's why we now really want to see screening to be part of what we try to do in the next few years as we move towards elimination. So to give a case example of what we are finding in Kenya, we've been doing this for many years now. There's been many programs that have been funded by organizations like USAID and CDC to help us do research projects, help us do programs. There's many NGOs like PATH and universities like UCSF, along with local universities like University of Nairobi, Kenyatta National Hospital, and KEMRI, that have done many wonderful programs that have done lots of screening, published a lot of papers in terms of research. We've come a long way in Kenya over the last 20 years in doing work in this area. And similarly, we have awareness campaigns that have been promulgated by hospitals like Aga Khan University Hospital, where I've worked for several years, to offer subsidized screening. And so we've come a long way in terms of raising awareness and women becoming more aware that you can get screened, and this does make a difference for them. And we have support of the government. The Kenya Ministry of Health has been great in trying to explore ways to integrate reproductive health services or screening with HIV services, as well as publishing national cancer screening guidelines that have made a difference for us over the last decade or so. At the same time, even with all the work that has been done over the past 20 years, even with the Ministry of Health supporting this and the awareness campaigns that are there, it has been shown in a recent study that despite these 20 years of recommendation strategies, only 16% of women have been screened for cervical cancer. So it just shows that, what the challenges are there, that even in a place like Kenya, where we've done so much work and we've come a long way, we still have barely touched the surface in terms of getting women screened. This is highlighted by the vaccine effort that was started late last year. The government had a launch for the HPV vaccine in October, but it wasn't just several days later where the Catholic Church came out and cautioned the government against the vaccine side effects, and we had big pushback from church groups and anti-vaxxers in Kenya to actually inhibit and stop what we're doing there. So it's been very frustrating. It shows that anti-vaxxers, these are issues that hit not just high-income countries, but LMICs. This is the issue we have to face. So I can't talk about Kenya without also talking about the safari, and as I get there, I want to talk about the current situation. And Michael, you're supposed to talk about what is the current situation. So what is the current situation? So I want to now show a picture of the elephant in the room. What is the elephant in the room about the current situation with screening? Well, the elephant in the room, I give you one guess, is COVID. It is what is most current and also what is most disturbing about what we're doing in screening. We have issues in Kenya where patients are afraid to come into clinic, afraid to come into the hospital because they don't want to get COVID. Doctors themselves are turning patients away, saying, you're at risk for coming here. And we now have different countries in varying levels of a COVID surge actually having hospitals overwhelmed so that patients can't come into clinic and they're being literally turned away. So COVID is something that is really impacting us. I'm not able to even do the HPV screening programs that we have. Everything's been on hold for the last 4 to 6 months or so. It looks like it's going to be on hold indefinitely. it's something that is going to need to be addressed and is really having a huge impact and is probably going to be with us for years to come. Even to get back to where we were before, COVID is now just undermining health systems. And as we see in America, where I'm based now, in Kenya, there's going to be a shakeout in terms of medical establishment about who's going to be able to afford to provide these services as now health systems really buckle underneath the strain of what COVID is doing, and what that does to not just screening, but even the vaccination campaigns is very disturbing to have to predict. So in summary, LMICs really shoulder the disproportionate burden of cancer. There are many barriers I described: economic, social, and political. HPV testing is promising, but challenges still remain. It's not the panacea that perhaps some of us hope. And despite the HPV vaccine, we still need to have screening in order to really make a difference in mortality and reduce incidence and really reach those elimination targets that Natalie had described before. And it's something that the elephant in the room they have to is really COVID-19. It's not something we can avoid. It really does affect what we're going to do, and probably for the near future. So with that, I'd really like to thank all the collaborators I've had in doing this research and implementing these programs in Kenya. And I'm happy to answer questions at the end of this session. Thank you.